Okay, so I will discuss the issues of diabetes, lifestyle, related issues. And the one thing, of course, we have to remember, a very well-known fact that diabetes is increasing cardiovascular risk tremendously. These are the data from the big US multiple risk factor intervention trial. And for instance, at any level of blood pressure, you see that there is a gradient which is staying approximately the same across the range of blood pressure distribution. Now, when we look at the multivariate analysis of a different data set, these are our own data from Finland, and risk of stroke, you see that very well-known risk factors are always coming up in the analysis, but the role of diabetes as a risk factor of stroke is really outstanding. It is bigger than smoking and some other factors. Now, how are we defining diabetes? There has been, during the last 30 years, a consensus what we call diabetes, although there is a little argument between the Europeans and Americans on certain cut points. But in principle, we can measure fasting glucose level and have a diabetes defined here, 7 millimoles or 126. And the other way would be to have a glucose tolerant test and have a 2-hour post-load glucose 200 defining diabetes. And then there are categories which are sort of borderline considered to be also important for many reasons, especially because these are the risk categories to actually progress to diabetes, but also otherwise. And when we looked at the big European data, for instance, in the non-diabetic individuals in the population, we found out that many people actually had diabetes which was asymptomatic. And this asymptomatic diabetes is associated with increased cardiovascular risk and increased risk of stroke. So asymptomatic diabetes is not a mild condition, and the problem is that diabetes will only cause symptoms after about 10 years of being there. So people are walking around with the high glucose levels without knowing it. And this is an issue which has so far not been solved properly. Now, diabetes is also an issue in numbers. International Diabetes Federation every year is updating the numbers, trying to make use of published data. And these are already old, from about 2 years ago, when about 400 million people were considered diabetic in the world, and estimates were about 600 million for 2035, and now today this estimate is somewhere at 750 already. So huge number of individuals, and if you think that all these individuals are at the high risk of cardiovascular disease and other complications, then one can understand that this is really a huge growing problem, and it's very expensive. Diabetes is not expensive, but the complications, if you get the stroke, if you get the dementia, and the other kidney complications, it will be extremely expensive. Now, we all know that we classify 2 types of diabetes, type 1 and type 2, and the type 1 defined as a absolute loss of pancreatic beta cells, so that the insulin therapy is a must for survival. While in type 2 diabetes, people have a pancreatic beta cells left, but they are not working properly, or somehow the insulin which is secreted is not working in the tissues properly, and the glucose levels are very high. So the majority of the cases are type 2 diabetes in the population today. So we have data, very much data on type 1 diabetes, especially in children, because it's relatively easy to collect from the pediatric wards. All children in the developed countries are hospitalized at the time of diagnosis. So, for instance, in Finland, which has the highest incidence of type 1 diabetes in the world, you see here we had data from 1965 onwards, and there is a linear increase about 3% per year. And more recently, it has even the trend has even got steeper, and this also illustrates that it's both in boys and girls in the same way. A little bit more in boys, but very, very small sex difference there is. We also did the global incidence study in the 1990s, looking at the incidence under the project called the Diamond, and we had about 100 countries included in this effort. And if you look at the trends around the world, everywhere, only in the small populations in the West Indies, there was a negative trend, but this probably is due to some technical issues of the small countries. But about 5 to 3% increase every year, everywhere in the world happening for type 1 diabetes. Now, type 1 diabetes already, although it's childhood onset disease quite often, but when people are growing older, they are at the risk of coronary heart disease, strokes. And here are our data from Finland, where we followed the people who had diagnosed before 1980 and saw what happened to these individuals regarding coronary heart disease and stroke. And you can see that both in men and women, approximately the same number of individuals developed these diseases. Diabetes is interesting because in non-diabetic population, men have a 2 to 3 times higher risk of cardiovascular disease, but in diabetic populations, this disappears. So women with diabetes are on the same line for cardiovascular disease, whether coronary heart disease or stroke. Now, why are the type 1 diabetic patients developing coronary heart disease and stroke? You can see here, they will develop it if they get nephropathy. There are very few cases in the non-nephropathic population. About 1/3 of diabetic patients will develop nephropathy. It is assumed that there is some genetic trait why it happens, but the genes have not been found so far. So 2/3 are remaining free of nephropathy. But you see the rates, they are so much higher for stroke and coronary heart disease, so that the relative risk estimates are somewhere 7 to almost 10-fold compared with the non-nephropathy patients. And the same happens, exactly the same happens in women, as I showed earlier for men. And here you see the cumulative Kaplan-Meier curves of cases when these patients grew older and developed nephropathy. You see here that the risk of stroke is increasing rapidly, so that at the age of 50, about 20% of these patients with type 1 diabetes and nephropathy have had a stroke event. So for young individuals, of course, we know that many strokes under the age of 50 happen in type 1 diabetic patients. And the type of stroke in type 1 diabetes is usually ischemic stroke. About 20% have a hemorrhagic stroke in our data series, and a few patients had a subarachnoid hemorrhage, which is considered somehow that subarachnoid hemorrhage. Some people say that subarachnoid hemorrhage is not occurring in diabetic patients, but it is not true, at least in our population, which has a high risk of both conditions. These are the data from the Oxford registry, and just I would like to point out that the lacunar infarcts seem to be in these patients with diabetic nephropathy quite common. So there is kind of a global leakage of vessel walls causing nephropathy, causing many other conditions, including cerebrovascular disease. Then we looked in our other database, the stroke register, also the distribution of type of stroke in diabetic, non-diabetic individuals. Here you see there are mainly type 2 diabetic individuals here, a few type 1s, but mainly 80% type 2s. So about 10% of diabetic individuals had a intracerebral hemorrhage, so where it's more common in non-diabetic individuals. And a subarachnoid hemorrhage, there is a big difference. And similar data are for women, and again, about 7% having intracerebral hemorrhage and in diabetic, while it's twice as many in non-diabetic individuals. Now, the stroke prevention is certainly an issue which is important, and there are many different recommendations today, and probably the best recommendations are coming from the United States, where they update the American Heart Association plus many other organizations there every couple of years, their recommendations for prevention of cardiovascular disease and stroke. And the data have been accumulated in many different countries and studies to look at the lifestyle factors. These are the recent data from Sweden, where they looked at the high-risk men, high-risk defined by hypertension, cholesterol, diabetes, heart failure, atrial fibrillation. And the big questionnaire survey was done, and then the clinical examinations, about 40,000 people. And then they had a 10-year follow-up, during which about 100 cases of stroke were identified. So definition of a healthy lifestyle was in this study based on 5 lifestyle factors, which were diet, smoking, physical activity, body mass index, and moderate consumption of alcohol. So simple score from 0 to 5 was then calculated if there was a factor. I'm not going to read these details here. And they used the reference group, the individuals who had either 0 or 1 healthy lifestyle factors in their statistical analysis. And here you see the data from this analysis. So there were not too many cases here in the individuals who had all 5 healthy lifestyle factors. because the risk was extremely low, almost 70% lower than the reference category 0 to 1 healthy lifestyle factors. And in men, there was a linear, in these men, there was a linear trend, the bigger number of healthy lifestyle factors, a lower risk. For ischemic stroke, the results are very similar, of course, because the main category of stroke, again, you see a linear trend, and they also had the classification to hemorrhagic stroke, and again, there is a trend which is visible here, but if you like, that really only started after, let's say, 3 to 4 healthy lifestyle factors. Before that, there was no real trend for hemorrhagic stroke. The same investigators in Sweden had another Swedish cohort, now women from the mammography cohort, where they had also questionnaires of the lifestyle and the follow-up to ascertain the stroke cases, and they had about 1,500 incident stroke cases, and again about 10 years of follow-up. So when they looked at the single variable here of a lifestyle, clearly for the hemorrhagic stroke and also for cerebral infarction, smoking seemed to be the one which is most prominent from this. Physical activity had as a single factor, not effect on the hemorrhagic stroke, and body mass index had an inverse relation, and even significant so. So it's interesting to see that the single factor did not contribute too much, but when they created a score of number of healthy lifestyle factors, again there was a clear nice trend. The more healthy lifestyle factors these women had, the lower was the risk of stroke, total stroke here, cerebral infarction also. Now we have done a similar analysis in Finland, who had about 37,000 individuals who were studied, and then we followed them up through the hospitalizations and mortality data. Again, we looked at the single factors first, how they operated the hazard ratios for physical activity. There was a positive but not significant. Again, smoking was rather strongly associated with the risk of stroke or never smoking to avoid stroke events. But similarly to the Swedish data, there was very little to see for the single individual risk factor. Whereas when we combined them into the score, here those who had all 5 factors, healthy lifestyle factors, they had about 60% lower risk of stroke. Whether it was ischemic or hemorrhagic, there was no difference. And this trend here was nicely linear and independent of other factors, because the multivariate model, this model 2, included many different risk factors, potential confounders that we had measured. For women, the results are very similar, but here the effect of healthy lifestyle may be even stronger, so that about 70% lower risk was identified for those who had all 5 healthy lifestyles. So the lifestyle matters, and the most important issue with the lifestyle is that there is not a single lifestyle factor which is determining whether you get the stroke. You have to look, as we always speak, that we have to see the individuals, we see the patients as a sort of a whole, and not only try to concentrate on the single items. So this is the same for lifestyle. We categorize people then for age, hypertension, history of diabetes, cholesterol. And you see here that very little was different, except that the non-hypertensive individuals with a healthy lifestyle had extremely low risk. It was 86% lower if people had no hypertension and 5 healthy lifestyle factors. But otherwise, not a very big difference by any of these characteristics. Now, the other way to look at the importance of other factors with a stroke is to take the comorbidity into account. For instance, in the US, there has been over the years a clear trend in all ethnic groups that more and more patients who are hospitalized with the acute stroke are diabetic. So in the black population, it's now exceeding 40%. In the white populations, it's about 30% now. So this is something, comorbidity with a stroke. But it's not only diabetes. There are so many other conditions that can be seen with the stroke patients, and some factors that may be less common in stroke patients than in the other hospitalized patients. So the most common, of course, is the cardiovascular or cardiac event, the coronary heart disease, myocardial infarction. We know that when people had the myocardial infarction, there is a high risk of stroke afterwards. It's not as high as for recurrent myocardial infarction, but it is much higher than in those individuals who did not have a prior myocardial infarction. So it's about threefold increase here, and in the non-diabetic individuals. And in diabetic individuals, you see here that these are becoming even much higher. So the individuals with a myocardial infarction has a tendency to get stroke, as we know, and the longer follow-up from the myocardial infarction, the higher the probability to have a stroke seems to be. But if you look at here, the first 4 months, already there are quite a huge number of individuals. If you take then the 12 months, about half of them actually get stroke in the first 4 months. And this means the bad news for the prognosis, because if you have a myocardial infarction with stroke, the survival probability is clearly reduced, especially in the beginning of the event, but also even later it continues to be worse. And same happens in diabetic patients. So especially those myocardial infarction patients who have diabetes, they are the ones who are prone to get stroke. So that the cardiologists should be very careful when they are examining the patients with myocardial infarction and identify that there is diabetes, because it's not then only a cardiac problem in the future, but also the other diseases like stroke is likely to occur. And it happens especially in the younger individuals here. It's not so common in the older individuals, but in the younger individuals, it's so. Now, the diabetes itself can be prevented, and this has been proven by randomized trials. This is a design of our trial in Finland we carried out some time ago. Very simple lifestyle intervention, not too complicated, and the targets being rather modest, which are basically the same as recommended for healthy lifestyle anybody in the population. So we randomized people into the intervention and a control group. Control group, of course, had to get some general health advice, but no individualized counseling. So in this trial, we showed very clearly that in a few years' time, there was a very significant reduction in risk of developing diabetes. Actually, this 58% reduction was much bigger than we had originally estimated. The other thing, what you see here is that the difference between groups started to be visible very, very early on after the study was going on. Now, our study was the first proper randomized trial in diabetes prevention, but afterwards there have been other trials. And very interestingly, if you take this 58% reduction, the numbers are almost identical in other trials. So clearly, we have evidence that diabetes can be prevented by healthy lifestyle. Now, interestingly, there was a symposium in the Netherlands among the nutrition scientists, and they decided to vote for 15 most important nutrition research findings since 1976. So you see here the list. There are many issues related to obesity, but also I was very pleased to see that number 11 was diabetes prevention. Unfortunately, as you can see here, that stroke prevention is not listed here for the nutritional achievement. Now we have followed our study for further and seen that after the intervention was over, the difference remains, and especially it happens because these individuals who change their lifestyle, having 4 or 5 healthy lifestyle factors that were the targets, nobody became diabetic. It's again the same finding with the healthy lifestyles as I showed for stroke, and it's just true for diabetes. And we looked at the prospective study, and this is not our trial, but the independent prospective study, healthy lifestyle factors here. And when we looked at the development of diabetes, there was a linear trend here. 90% reduced risk of diabetes if people had all 5 healthy lifestyle habits. So really the same factors are playing a role for diabetes, cardiovascular disease, stroke, and so on. So we also have a possibility to look at the risk of diabetes in the simple way using a very simple score that doesn't require blood drawing at all, and just a few factors measured. We had a study where we actually validated this and looked at the cases of new diabetes and found out that individuals who had a high risk score for diabetes, almost everybody in 10 years became diabetic, and at the low level, hardly anybody became diabetic. But at the same time, we had a possibility to look at also the cardiovascular events. And the same simple score that we are using to predict diabetes is very good in predicting stroke and coronary heart disease incidence as well. So this proves a point that the similar factors are behind there, and we certainly have to consider joining the forces in these disease preventions. And my last point is whether this prevention of diabetes leads to prevention of cardiovascular disease. And yes, in a Chinese trial, they have now 20-year follow-up. They looked at the microvascular disease, retinopathy, and recently they published also the mortality follow-up, and that the mortality after 10 years of the trial started to separate between, they had a 6-year intervention originally and then just follow-up. And when they looked at the different categories of cardiovascular disease, you see here the main difference really came from stroke and a very significant 64% reduction in stroke rate in this study, if they could prevent development of diabetes compared with those who developed diabetes during the trial. So the diabetes stroke issue has been now studied and also from a genetic point of view. This trial, Predimed, was using a simple Mediterranean diet and mainly virgin olive oil. That was the main issue in the whole thing, and then they had some other recommendations as well. They have shown very nice results in the prevention of diabetes, prevention of dementia, and also prevention of stroke. Here you see that there is a very significant reduction in the risk compared with the control diet, and this is statistically significant. But in this study they looked at the clock gene, which is regulating circadian rhythms in us, and they saw that a certain genotype, the allele G, inherited, actually had a lower progression to stroke compared with those who had inherited C allele from both parents. But it was only in the Mediterranean diet group, not in the control group. So there was diabetes development that way. And when they looked at the diabetes rates in the diabetic, type 2 diabetic individual, they saw that these people, again, who had inherited G allele, they had a reduced risk of stroke, but not myocardial infarction. So this is something interesting. We have many different ways of looking at like a chocolate, for instance. If you are having a chocolate eating habit, you have a 30% reduced risk of stroke. Good news. When you look at the coffee drinking, good news. If you drink a lot of coffee, the risk of diabetes goes down. And in diabetic individuals, when we looked at the risk of stroke, if you drink about 5 cups of coffee, then you have about 35% reduced risk of stroke. And then it goes back to the initial level. There are studies from the US showing approximately the same. So the 5 to 6 cups of coffee a day, please, that is something that you should consider. Thank you so much.
Thank you. Thank you. Impressive work. I think we have time for one quick question. Yes, please, Ms. Feld.
I would like to ask, what do you think is the best way to diagnose diabetes in the acute stroke patient? He cannot swallow and he has stress.
Well, we did a study. The Carl and the others were carrying out the study that was in cooking at that time, and the best way really is to do the glucose 2-hour glucose tolerance test. There is hardly any other way. I However, I would say that maybe 1 hour glucose tolerance test would be sufficient, 1 or 2 hours anyhow. If you just measure fasting glucose, you will get the very variable results, and most of individuals have a postprandial glucose elevation, and therefore this is important. If you measure hemoglobin A1C, you pick up about 30% of the undiagnosed cases of diabetes. So it's really a glucose tolerance test, which is the only proper way. And you can do it at a certain time when the patients are well enough and stable in their treatments.